Turn of the century, the great William Osler, as shown in the first slide. Need the lights down, please. Focus. This slide demonstrates Sir William Osler. And Sir William Osler said that the art of medicine is in the observation. A contemporary of Sir William Osler, shown in the next slide, was Sherlock Holmes. Sherlock Holmes put it somewhat differently to Dr. Watson when he commented, "Quite so, Watson, you have observed, and yet you have not seen." Today I would like to combine these two men together for you to show you how the medical detective can use the skills of observation to wring a confession from the extremities, to trick the face into an unwitting admission, and to force the chest to betray itself and reveal the underlying cardiovascular pathology. When Raynaud's phenomenon occurs, as shown here by the dusky peripheral cyanosis, one can suspect that a collagen vascular disease is in the not too distant future. For example, on the next slide. The many external changes of systemic lupus erythematosus include, as shown here, the inflammatory depigmentation and scarring on the malar area and on the forehead. A very characteristic vascular blushing, localized over the fingers but sparing the knuckles, seen here in this patient with systemic lupus. A brownish depigmentation of the palms, illustrated here. And of course, arthritis in this gentleman who presented with systemic lupus erythematosus. Cardiovascular problems are legion. They include pericarditis, an example of which is shown here, but also verrucous endocarditis and myocardial lesions with arrhythmias or congestive heart failure. Another collagen vascular disease, this hand demonstrates, as Sir William Osler said, a disease in an ever-shrinking, slowly contracting skin of steel. Depigmentation, ulceration over the knuckles. Another hand showing hyperpigmentation, piling up of butysis. Skin over the face is often involved also. Here's an example with the tightly contracted skin over the facial bones, producing a gaunt or skeletal appearance. And the cardiac involvement varies. This is an example of sclerodermatous involvement of the kidneys. Focus this slightly, please. This patient that I've just shown you had hypertensive cardiovascular secondary to this. They may have myocardial disease, pulmonary fibrosis, resultant cor pulmonale, cardiac fibrosis, or thickening of the aortic or mitral valves. A related disorder, possibly the same disorder, is the CRST syndrome. C for the calcinosis, shown here extruding from the knee in this patient. R for the Raynaud's phenomenon, same patient, seen here in the toes. T for telangiectasia, localized here over the fingertips, and on the next slide, on the lips, the CRST syndrome. The violaceous rash or discoloration of dermatomyositis can often be seen decorating the upper lids, as shown here, and this disease can be followed by pericarditis or arrhythmias, congestive heart failure. A related disorder is polymyositis. This is a young girl, 15 years old, who presented with peripheral muscular wasting, contraction of the fingers, a ventricular gallop, an inferior dead zone on her electrocardiogram, and cardiomegaly, all due to polymyositis. Acute rheumatic fever may express itself by nodules, easily seen here in the base of the thumb. Sometimes the nodules are not so quickly found, but may be hidden, as seen here next to the spine in a patient with mitral valvulitis. Though erythema marginatum is the most specific rash for acute rheumatic fever, this is quite unusual these days, but more common in our own experience is an urticarial rash, demonstrated here in this young boy with acute rheumatic fever. This is an example of the pathology that one could anticipate, the thickened, scarred, distorted mitral valve that follows from rheumatic fever. The culprit here is polychondritis, a disease which can destroy cartilage anywhere, producing the saddle-shaped deformity of the nose, a cauliflower ear, and distortion of the aortic ring producing aortic regurgitation. Not a usual lesion, one that you may not see too often in practice, but as Sherlock Holmes once said, it's an old maxim of mine that whenever you have excluded the impossible, whatever remains, however improbable, must be the truth. Subcutaneous loss of interosseous musculature, boxing of the wrists, ulnar deviation of the fingers. Next slide. Subcutaneous nodules, all typical signs of rheumatoid arthritis. Not so easily recognized, however, is the frequent occurrence of underlying cardiovascular disease. In autopsy, a high percentage of these patients are found to have pericarditis, possibly missed because, as William Osler said, pericarditis is diagnosed in proportion to the care of the examination. They may also have myocardial granulomas involving the base of the aortic or mitral valve, producing regurgitation and occasionally stenosis. A disease which superficially resembles rheumatoid arthritis is Charcot's arthritis. Charcot's arthritis, however, differs from rheumatoid arthritis because it follows repeated attacks of rheumatic fever. The fingers are often deviated in an ulnar fashion. However, they can be freely returned into a midline position. The finding of xanthoma in this slide lent to us by Dr. Fredrickson warns of an underlying hyperlipidemia, which may, of course, predispose to coronary artery disease. I think most of us would have found this on the physical examination, but at least by percussion. But sometimes the xanthoma may be hidden. They may be found only tucked away among the knuckles here and brought forth only by having the patient make a fist. Or they may be seen on the tendons, as shown here, and sometimes just over the elbows, as shown here in this patient, a young fellow aged 28 with a myocardial infarction, total lipid count of close to 3,000, very high triglycerides attested to by the reddish discoloration of the xanthoma, which usually means a high triglyceride count. The finding of xanthelasma in the palm, planar xanthelasma, is fairly specific for broad beta or type 3 hyperlipidemia, an almost pathognomonic sign in this disorder, which is associated with coronary disease. Xanthelasma is a familiar finding. It may encircle the arteries here, much as the coronary atherosclerosis in these patients may encircle their coronary arteries. The prototype of a coronary prone individual is an individual that's aggressive and tense, and they may have the following physical finding. In the wake of a myocardial infarction, the patient may develop the shoulder-hand syndrome, a hand which displays discoloration, is painful, and may be stiff and swollen. The complaint of the myocardial infarction, however, that is the chest pain, may not be very prevalent. He may present several weeks later, and his major complaint is that stiff, swollen hand. Another physical sign we've seen following myocardial infarction is clubbing. Bright red tips of the fingers here in this elderly gentleman appearing after each of 3 myocardial infarctions. Another disease that can involve the coronary arteries is polyarteritis, showing here gangrenous changes and ulceration in the peripheral digits. An uncommon cause of myocardial infarction in an adult, but when myocardial infarction occurs in infancy, it's often due to polyarteritis. Here's such an example. A young infant that was seen here who had polyarteritis involving the coronary artery with thrombosis and this gangrenous aneurysm of the anterior wall. The polyarteritis may be difficult to spot, however, and as in this patient, was found only as a small terminal ulceration of the fingertip. The diagnosis of bacterial endocarditis should be suspected when one is confronted by an Osler node, seen here in the terminal phalanx of a narcotic addict with tricuspid staphylococcal endocarditis. Focus, please. This is a splinter hemorrhage Not specific for endocarditis. It can occur due to trauma, can occur in several infectious diseases, but a good sign to look for because it leads one to the diagnosis of an unexplained fever or cardiac murmur. Another sign of endocarditis may be petechiae. This was an elderly dentist who had had recent dental work, was unaware that he had valvular disease, presented with this petechial rash, and had mitral staphylococcal endocarditis. The petechiae might not be so easy to spot, however, and may be hidden, as in this patient, in the buccal mucosa, and found only by repeated examination. As Sherlock Holmes might have said, if Watson had missed this lesion, not invisible, but unnoticed, Watson, you did not know where to look, and so you missed all that was important. Subconjunctival hemorrhage, another good finding in bacterial endocarditis. And on the next slide, an acute ophthalmitis. We saw 2 patients within the space of several weeks present from the ophthalmology service who came in because of an acutely inflamed and infected eye due to pneumococcal endocarditis with embolism to the eye. The next slide shows the unfortunate aortic valve of this patient who died very shortly thereafter with the massive destruction of the leaflets and the vegetations, all due to pneumococcal endocarditis. Reiter's syndrome can be diagnosed by the characteristic triad of arthritis, shown here, keratodermia blenneragicum, seen in the usual location here, and severe conjunctivitis, as in this patient demonstrated here. Reiter's syndrome does not usually have associated heart disease, but when it does, it can include pericarditis or heart block, including a recent patient that we have seen with second-degree heart block associated with Reiter's syndrome. The diagnosis of high-output congestive heart failure may be obscure unless one realizes that this may also be due to shunning of blood through extensive skin lesions, an example of which in this slide is Kaposi sarcoma, and on the next slide is psoriasis. Many of these patients, even if it's not clinically realized, have a high cardiac output because of the extensive flow of blood in these lesions. The finding of cyanosis and clubbing is typical, of course, for congenital heart disease, an example of which is shown here in a patient with tetralogy of Fallot. Their tongues may be as purple as if they'd been sucking on a popsicle, as in this patient with an atrial septal defect, pulmonary hypertension, and reversed right-to-left shunting. A very good finding for a small or intermittent right-to-left shunt is terminal tuft erythema, redness of the fingertips, as shown here in this patient with an AV communis defect, due to a small or intermittent right-to-left shunt. The finding of differential cyanosis can be very valuable in making very specific physiologic implications. This is a patient with an atrial septal defect, pulmonary hypertension, and a reversed right-to-left shunt. Notice that the cyanosis and the clubbing is identical in the fingers and in the toes. As compared to this slide lent to us by Dr. Perloff, which shows cyanosis and clubbing of the toes, cyanosis and clubbing particularly prominent in the left thumb here as compared to the right thumb. This is an example of differential clubbing due to a patent ductus arteriosus, normally related great vessels, and pulmonary hypertension bringing desaturated blood to the left arm and to the legs. If one finds that the fingers are more desaturated than the toes, one should suspect transposition of the great vessels, pulmonary hypertension, and a patent ductus arteriosus, this time bringing saturated blood to the lower extremities. Sarcoidosis may be a difficult disease to diagnose sometimes, but it does have many external changes. This is an example of a patient who presented because of lacrimal gland enlargement. A characteristic eruption in sarcoidosis is this waxy papular eruption seen here on the cheeks. Sarcoidosis may involve the heart in several ways, particularly involvement with myocardial granulomas, which may be clinically silent, or be associated with recurrent ventricular tachycardia or with heart block. There may be diffuse involvement of the lungs with secondary cor pulmonale. This is an example of the sarcoid involvement of the paratracheal nodes in a patient that had diffuse myocardial fibrosis. This is not an unusual congenital defect of two right hands, but rather a patient on the left side here with hemochromatosis, displaying this rather characteristic brownish discoloration, contrasted to a patient without hemochromatosis on the right. The iron deposits may also invade the heart and the pericardium, producing a restrictive type of myocardopathy or pericarditis. The finding of cold hands with puffy, coarse skin should make one suspect an associated hypothyroidism, as in this patient with a PBI of 2.0 and a pericardial effusion. This is not a young lady charmed by my presence in the room, but rather, as shown by Dr. Wenger earlier, a patient with hyperthyroidism, a disease which frequently can cause high-output heart failure or atrial fibrillation. Easy to diagnose in this young lady, the marked exophthalmos, but may be easily missed in the elderly patient who does not have such striking external changes due to hyperthyroidism. All that is exophthalmos is not due to hyperthyroidism. It may be due to high venous pressure or severe tricuspid regurgitation, an example of which is shown here. Moderate amount of exophthalmos in this patient who had marked kyphoscoliosis with tricuspid regurgitation. And on the next slide, close-up of her neck veins showing the marked increase in venous pressure in this patient. The exophthalmos varied according to the clinical state of her congestive heart failure. When the patient develops the calamitous onset of cyanosis, seen here in on the nose and the ear and so forth, sweating and dyspnea, one can almost diagnose with great certainty a large occluding pulmonary embolus. Next slide shows such an example. This is an open right ventricle, pulmonary artery, and here is a large occluding pulmonary embolus completely filling up the pulmonary artery. The diagnosis of dissection of the aorta was suspected by the finding of unilateral neck vein distension, seen here on the left when compared to the right. This was due to a dissection of the innominate artery, compressing the innominate vein on the left, but not the same vein on the right. And this is an example of the underlying pathology. Here is the intima, here is the dissection with the hemorrhage and the adventitia out here. One of the most classical hands in medicine is the hand of trisomy 18 disorder. The fifth finger overlaps the fourth, second finger overlaps the third, the hand is tightly clenched. Another example of the same disorder showing you that many infants, of the infants that have this disorder, it looks almost exactly the same. A high incidence of congenital heart disease, particularly ventricular septal defect in this disorder, also abnormal fleshy looking valves and patent ductus arteriosus. Another pathognomonic hand is trisomy 13-15 disorder. These infants have polydactyly. Their fists also may be tightly clenched. They have trigger-like thumbs. Their ears are low set and malformed. They have large cleft palates, absence of ocular tissue, ventricular septal defect, and dextrocardia. All the trisomy disorders, of course, have a high connection with cardiovascular disease. This is the familiar Down syndrome, the brush-field spots, the protruding tongue, abnormal hypertelorism, and so forth. The next slide shows the hand in this disorder, broad and square with a simian crease. AV communis defect, atrial septal defect, ventricular septal defect are the cardiovascular implications. This is a face typical of mucopolysaccharidoses, the broad forehead, the upturned nose, the broad mouth, large tongue. You can't see the widely spaced teeth. The hands are usually broad and square. They're of course dwarfed and have many other external changes. Coronary atherosclerosis is a frequent cause of death in these infants and may also have endocardial fibroelastosis, or as shown in the next slide, they may have nodular excrescences, sharpened slightly, as seen here in the mitral valve. A related disorder of mucopolysaccharidosis is Morquio syndrome. They're dwarfed, as in the Hurley syndrome, but they differ by having fairly normal intelligence, and their cornea are not usually cloudy. They have a barrel-like chest and a short neck. Their hands may be abnormal. This is one example here, short, stubby hands with sausage-like fingers. Next slide shows another patient with Morquio syndrome showing contractions of the hands. Valvular disease, aortic regurgitation has been described, and the one patient that we have followed to autopsy here, severe primary myocardial disease, and second, and also endocardial fibrosis is shown here. The salient features of Marfan syndrome is a head that's long and narrow, as if it had been turned sideways and ironed somewhat. Next slide shows the high arch palate in these patients, the dislocated lens. No question here about the striking arachnodactyly that this patient has. The cardiovascular involvement varies from aortic aneurysms, dissection of the aorta, aortic, mitral, or tricuspid regurgitation, redundant chorditendiny. Here's an example of the water flask deformity with aortic regurgitation in one patient. Here is the first patient I showed you, a young girl who was operated on here at the age of 16 for this large aortic aneurysm, massive aortic regurgitation, had replacement of this with an aortic valve at the age of 16 and is now doing quite well. In the Ellis von Creveld syndrome, the upper lip is frequently tied down to the alveolar ridge by these multiple frenulum. They have polydactyly. Their fingernails are abnormal, as shown here, ectodermal dysplasia. Their cardiovascular involvement, a very high incidence of a large atrial septal defect or common atrium. This is an example of a large atrial septal defect with only a remnant of an atrial septum here. An uncommon disorder, to be sure, but as Sherlock Holmes might have commented, I've already explained to you that what is out of the common is usually a guide rather than a hindrance. In solving a problem of this sort, the grand thing is to be able to reason backwards. Defects of the radial aspect of the hand have a very high connection with defects of the atrial or ventricular septum. This is an example of the Holt-Oram syndrome, in which the thumb is hypoplastic, located in the same plane as the rest of the fingers, or maybe as this thumb larger than normal. They may also have triphalangeal thumbs. Atrial septal defect is the common cardiovascular problem in these patients with the Holt-Oram syndrome. A similar disorder is ventricular radial dysplasia. The thumb is also hypoplastic, but the associated defect is ventricular septal defect. It differs from the Holt-Oram syndrome in that it is not known to be transmitted as a genetic disorder. This is Turner syndrome. You can recognize the webbing of the neck, the broad chest. You can't see the low hairline here. Of course, the gonadal dysplasia, the cardiovascular disease that these patients usually have, coarctation of the aorta. A disorder that superficially resembles Turner syndrome sometimes and is confused with it is Klippel-Feil syndrome. Typical of this disorder is the marked webbing of the neck, the low-set malformed ears. They have a low hairline, many vertebral abnormalities, and their cardiovascular defect is a ventricular septal defect. A hallmark of the Rubinstein-Taybi syndrome is this broad thumb, shown here, associated with a broad great toe. Their face is also abnormal, as shown here, and it's more easy to say that it looks like Danny Thomas and describe exactly what these infants have. The cardiovascular implications are a whole mixture, but approximately 30 to 40% of these infants have congenital heart disease. Hereditary hemorrhagic telangiectasia has a high incidence of pulmonary AV fistulas. The diagnosis can be made by the finding of telangiectasia, seen here, subungual area, here on the tongue. But But the telangiectasia may not be quite so apparent. This is a patient who had multiple pulmonary AV fistulas who presented with clubbing and cyanosis. Of the patients with pulmonary AV fistulas, 50 to 60% of them have hereditary telangiectasia. Conversely, 7 or 8% of patients with hereditary telangiectasia are said to have pulmonary AV fistulas. The telangiectasia may not be prominent. They were very difficult to spot in this patient, but looking at other members of the family, they could be easily found. The skin in pseudoxanthoma elasticum is coarse, thickened, somewhat lax. The usual location, the axillary fold or antecubital area, or of course along the neck. The skin around the mouth may sag, giving these patients a bulldog-like appearance. These patients have calcification of their arteries, which may be followed by angina pectoris or by claudication. This is a close-up of the skin in pseudoxanthoma, which has been described as having a plucked chicken-like appearance. This is a Pierre-Robin syndrome. These infants have a hypoplastic mandible. The tongue may fall back against the roof of the mouth. They have large cleft palates. Several of them have been described to have ventricular septal defects.